We are live.
A very good evening to everyone. Welcome to one more session of the walk-in patient, which, as you know, is a series of sessions of patients who walk in maybe to the general ophthalmologist clinic. And this time it's a turn of the patient with the dry eye disease who walks into the clinic. And we all know that there are many, many causes of dry eye. And our esteemed speakers, panelists, and chairs are going to take us through uh, today through the various causes as well as considerations that we need to have in patients with dry eye. So our chairs for today are Dr. Sayan Basu, Dr. Ritu Arora, Dr. Namrata Sharma, and Dr. Samir Basak. We have two moderators, Dr. Hunavar and Dr. Mathur. They'll join in later. And I'm here, I'm Somshila Murthy, and Dr. Supriya Sharma is the anchor for the panel. We have three expert panelists, Dr. Himanshu Mathalia, Dr. Geeta, and Dr. Bhaskar Roy Chaudhary, all of whom you know very well. And we have eight presenters, and they will be presenting a case followed by discussion. So everybody knows I'm very wicked about time, and we want to kickstart with the first speaker. The first speaker is Dr. Isha Chaudhary, and she's going to discuss her case of dry eye, followed by discussion. Over to you, Isha.
Thank you. I'll just share my screen.
While you're doing that, Dr. Basak, if you have any words to share.
No, this is a common subject, and very nice that you have an expert group of people who will be dealing with this everyday situation. And I think that's the case presentation and discussion will be fruitful to all the viewers. And we are learning every day about dry eye, about a lot of things. And again, new things we'll be learning today from our all levels of colleagues across the country. So, Isha, you can start your talk.
Thank you. Thank you, sir. So, good evening, everyone. I'm Dr. Isha, and I'll be talking upon on the workup of a patient with dry eye through a case presentation. So, this case is of a 52 years old lady, resident of New Delhi, a homemaker. She presented to us in February 2023 with complaints of both eye dryness, pain, and difficulty in opening eyes, especially in bright light, since 1 year. She had no history of any systemic illness, no history of small joint pain, no history of any prior contact lens use or any other prior ocular surgery. She was on no long-term treatment of any topical or systemic drug except for the use of lubricants before. Coming to the specific history for dry eye, we asked her about the screen use, both television and mobile phone, and the screen use was minimal. Her daily routine and activity was affected by dryness, and she needed to take rest often. She needed to use lubricants at least 5 to 6 times a day and sometimes more. She noted that her discomfort progressed towards the end of the day and was aggravated when the air conditioner or the fan was switched on. Vision fluctuation throughout the day was not uncommon. She also had an associated history of difficulty in swallowing food, sometimes with pain. There was no history of dental caries, but there was a history of dental sensitivity present. On examination, her general appearance and eye opening was uncomfortable. The rate of blinking was not increased. There was no evidence of rosacea on the face, and there was no parotid swelling. Her uncorrected visual acuity was 618 and 66 in the right and the left eye respectively. The near vision was N6. The distance vision improved to 612 in the right eye with correction. The lid margin examination was normal. The puncta was well opposed to globe, and the puncta was also seen well. The lashes were normal, and there was no lid laxity, as we can see here, that there were no collarettes seen on the lashes. There was expression of the meibomian glands was very minimal and from less than 5 glands. The fornices were deep. Unfortunately, we could not take any pictures on the very first day of her presentation because of her symptoms. So these are the pictures of the subsequent visit, and the congestion seems to have decreased after the initiation of treatment. On the examination, the conjunctiva was inflamed. The cornea appeared to be dry and lustreless. The anterior chamber iris and pupil was normal, and both the lenses had early immature senile cataract. So on the first visit, again for the fundus examination, patient was slightly uncooperative, but grossly the disc and macula was normal. And on the subsequent visits, we saw the fundus, and this cup disc ratio was around 0.6 to 0.7 in both eyes, and the IOP was 17 and 18 as per the Goldman application tonometry. So tests for dry eye that we do in our routine clinics can be divided into 4 categories, that is measurement of the tear volume, tear film stability, tear film integrity, and damage to the ocular surface. So we perform the following tests: Schirmer's, meniscometry, T-BUT, and ocular surface staining. Schirmer 1 in both eyes was 5 mm, and Schirmer 2 was 3 and 2 in right and left eye respectively. On the slit lamp examination, the tear film meniscus was measured less than 1 mm. The tear film breakup time was around 7 to 8 seconds, and on staining with sodium fluorescein dye, there was a diffuse staining. However, this is the improved picture because this was slight on the second visit. So Schirmer 1 is when it is without anesthesia and measures both the basal and reflex secretion. And Schirmer 2 is when after instilling topical anesthesia, the test is performed and only measures the basal secretion. Here's a very short video describing on how a Schirmer's is done. The strip is to be folded while inside the packet, and care should be taken that the strip is not touched with the fingers because the oily secretions from the fingers can interfere with the reading. And the strip is placed at the junction of the medial and the lateral 2/3 and 1/3. And it is placed there for 5 minutes. The patient can blink normally, but the fan should be switched off. And the light should be dimmed if possible. Here is a small video describing how a T-BUT test can be done. So when the strip is soaked, the excess fluid should be jerked out, and the cornea should not be touched while staining. Ideally, the measurement should be made 1 to 3 minutes after the staining is done. The patient is asked to normally blink thrice and then cease the blinking till instructed otherwise. The first random dry spot, which we see here, is the timing that is noted from the blink. So if we can see here, the first random dry spot can be noted here. So coming on to the non-invasive tests, the non-invasive tests are to be performed before the invasive tests. So, but I'm just describing them later. They were performed before. And the non-invasive breakup time was also decreased, which was 4.16 and 5.04. The eye blink was normal in the right and in the suspicious zone in the left. The lipid layer thickness was measured to be abnormal in both the eyes. And tear film meniscus was also found to be less in both the eyes. However, the meibomian gland loss was found to be in the normal range. So this is the summary, and as per the summary, the NIBUT, the lipid layer thickness, the tear meniscus was abnormal, but the MG loss was in the normal range. So based on the signs and symptoms, we diagnosed it to be a case of dry eye. Based on decreased Schirmer's and decreased tear meniscus height and with no evidence of MGD and gland loss, we diagnosed it to be a predominantly aqueous deficient dry eye. However, there were signs suggestive of evaporative dry eye as well. Because of the associated difficulty in swallowing, a high ESR, a positive ANA, the diagnosis of Sjogren's syndrome was made. Ideally, in such a case, anti-Rho and anti-La antibodies should also be performed, but as the patient could not afford more tests, the patient did not get it done. So a provisional diagnosis of primary Sjogren's syndrome was made, and the patient was also referred to a rheumatologist and an ENT specialist for confirmation of diagnosis. The topical treatment was initiated from our side in the form of prednisolone 1% eye drop in tapering doses starting at 6 times a day, and carboxymethylcellulose 1% every hour with a gel formulation 2 to 3 times a day. And the systemic treatment was started by the rheumatologist in the form of ocular oral hydroxychloroquine 200 milligram twice a day, and with oral prednisolone 40 milligrams once a day in tapering doses. At 2 months, the patient was symptomatically slightly better, but filaments were noted at this visit, and the treatment was continued. At 4 months, the surface was stable. Patient was advised a punctal cautery, but did not want to get it done. At 6 months, the patient suddenly presented with increase in symptoms and extreme difficulty in opening eyes for 2 days and was diagnosed as conjunctivitis. Eye drop prednisolone frequency was increased and an antibiotic was added. Improvement in the symptoms was noted over the next 2 weeks, and the steroid administration was tapered. In the next 6 months, the surface was more or less stable, and the patient was kept on a minimal dose of prednisolone of once a day. But at 1 year, a drop in vision in the right eye was noted to be 624, but the vision was not corresponding to the degree of cataract at that time. On dilated retinal examination, right eye maculopathy was seen. So as the patient was on HCQS and there was a maculopathy, even though the maculopathy due to HCQS does not appear so early, we did not want to continue HCQS, and it was stopped, and azathioprine was started instead. And in that interim period, the frequency of prednisolone was again increased. At 14 months, the patient presented with drop in vision in both eyes, and IOP was found to rise to 40 and 37 mmHg, and the cataract in the eyes had also advanced. So eye drop prednisolone was tapered and changed to fluorometholone eventually, and AGMs were added. Over the period of next few months, the IOP was controlled, the surface was stable, and a left eye cataract surgery was performed, and the vision improved to 612 unaided. So the take-home points from the presentation is that for a dry eye patient, one needs a systematic evaluation with detailed history taking. Correlation between the invasive and the non-invasive tests has been found, and hence non-invasive tests are not a must, but they help in diagnosis. And simultaneously, it's important to keep an eye on the side effects of the oral and the topical medication we give during the course of the treatment, because the side effects also have to be managed. So that's from my side. Thank you so much.
Thank you, Isha. I think extremely well documented case and full points to you, 100 out of 10 for sticking to time, as you said you would. So we'd like to throw open the discussion and invite the chairs, either Dr. Ritu Sain or Geeta. I think Dr. Basa may have stepped out. So if any of you can, the three aspects I wanted to know from you. So this patient walks into my clinic. I don't have any fancy dry eye equipment, but I do have my clinical examination skills. So what are the top 3 tests that you would like to do for this patient? I'd ask Dr. Ritu first, maybe, and then go on to Geeta and Sayan.
With these kind of patients, first I definitely like to see the corneal surface, and on my slit lamp, without touching the patient, see the tear film meniscus. What is the height of the tear film, and maybe also the brightness of the cornea. Also, I avert the lid, look at the meibomian glands. Like in this patient, at least in the clinical examination, I felt that meibomian glands were not in good shape. I was not seeing them very well. And, so mainly on my clinical examination, I would focus on this.
Okay. So Geeta, for this particular patient, would you also do some imaging of the meibomian glands with this kind of history and clinical picture, or what would your approach be on examination?
Yeah, I think excellent presentation, very well covered, both the positive and negative histories. I think history taking is very crucial in these patients, and we need to rule out all causes. We've come to the conclusion that you're dealing with aqueous tear deficiency. You need to rule out other causes of aqueous tear deficiency. The first thing that I would look for on the ocular surface is whether there are any signs of cicatrization or not. Because for me, the first question is, am I dealing with a dry eye with cicatrization or without cicatrization? And by cicatrization, I mean even very, very minimal subconjunctival scarring, which could be indicative of a past viral conjunctivitis, which can also sometimes lead to ATD. So this is going to be on clinical examination. And if you're looking at the main tests when you don't have fancy gadgets with you, then it would primarily be ocular surface staining, both the corneal as well as the conjunctival staining, use of the yellow filter, which enhances the conjunctival staining if you have access to only fluorescein, and Schirmer's. I mean, these are mandatory. Subsequent to that, I would be looking at the tear breakup time and the meibomian glands, because you do know that they get secondarily involved in these patients.
Okay, that's really good insight.
Can I say one thing? They get a history of difficulty in swallowing, which necessarily does not mean that there is a decreased salivary gland, because this could be also the first feature of progressive systemic sclerosis. And this patient was ANA positive. So I would think a little bit more than Sjogren's in this kind of a case.
So I was actually going to ask Sayan next about the same systemic history that Isha had elicited from her patient. So Sayan, how much? So what history, additional history, do you look at? Systemic history, and as Dr. Ritu pointed out, that having difficulty in deglutition could mean other things, in swallowing could mean other things.
No, firstly, I think very well presented by Isha. She really described the workup in very great detail, especially the history. That needs to be appreciated, as you said. And to answer your question directly, I think, the stepwise approach that she showed was quite appropriate. You're essentially trying to, first of all, establish if the patient has dry eye or not. And if the patient has dry eye, then what is the subtype that the patient has, whether it is primarily aqueous deficiency or meibomian gland dysfunction, or it's a mixed type. But usually, typically, one form of dry eye is predominant, and that is what you're trying to identify and treat. So in this case, it's quite clear that it's aqueous deficient. And like Geeta correctly mentioned, that if it is aqueous deficient, then you try to differentiate between whether it is cicatrizing or whether it's Sjogren's. In this case, of course, the patient has dry mouth. I'm not sure if the patient had any arthralgia or dry skin, but it looks like it's a case of Sjogren's. And if to diagnose all of this, like you correctly said, nothing fancy is required. You just require your slit lamp and your fluorescent staining, and that is enough, because you can do your Shermers, you can know if there's staining, and then you do a breakup time and you know that the patient has dry eye, and you can also tell what type of dry eye it is. So this patient has Sjogren's. The patient is ANA positive, and in Sjogren's, it's either primary or secondary, and you will find that out only when you do serology. You can have seronegative Sjogren's, you can have seropositive Sjogren's. Your seropositive Sjogren's might initially just show that the patient has anti-Ro-La, and you diagnose that patient as primary. Later on, the patient might show seroconversion and show that the patient has anti-CCP or anti-SCL, and you know that patient has something else. But primarily, you know that when you're dealing with aqueous deficiency without cicatrization, that this is an immunological condition, requires a rheumatological consultation. Patient requires some kind of systemic treatment, because that will prevent the other systemic features or manifestations or involvement from progressing as well. But in this case, of course, you can make out that is aqueous deficiency. So that part was very clearly diagnosed, and I think that the treatment is on the right line. So I would mostly agree with everything that has been discussed. Thank you.
Thanks, Sai. We have many more interesting cases coming up, and it's like how the music starts when we feel that the speaker is speaking too much in the Oscars. So I made Anaita put up her presentation, Anaita, and sorry, Sai. So for this case, we'll ask Himanshu and Bhaskar to be more attentive, because they're going to be first answering the questions for the discussion part. So Anaita is going to talk about a simple way of managing the patients. I asked her to focus on that aspect especially. Please go ahead, Anaita.
Thank you, Dr. SS. Thank you for giving me the chance to present here today. So today I'll be discussing some of the management pearls for aqueous deficient dry eye. So our patient was a 58-year-old gentleman who presented in January of 2019 with the complaints of photophobia and decreased vision. He was also a known case of retroviral disease on antiretroviral therapy. This is the clinical picture at presentation. So the patient had congestion in both eyes, and we don't have stained images at this point, but the patient had diffuse SPKs as well. And the Schirmer's test was reduced. There was a low value in both eyes. So he did not have any systemic complaints. There were no joint pains, no dryness of mouth. And based on this, we came to a diagnosis of both eyes aqueous deficient dry eye. And the patient was started on topical lubricants with steroids and cyclosporin. And he was advised to get rheumatoid factor and an ANA profile done. But the patient was lost to follow-up and directly presented to us after 4 years with complaints of extreme photophobia, and the visual acuity had now dropped to counting fingers in both eyes. We can see that the clinical presentation has also significantly worsened. There's a lot of congestion. There's a central corneal scar. And examination of the phonesis revealed that there was subconjunctival fibrosis with phonacial shortening. This is the right eye. And a very similar picture was also present in the left eye, which also showed subconjunctival fibrosis and shortening of the fornix. The Schirmer's was again reduced in both eyes, and based on this clinical picture, we suspected that clinically the patient may have ocular cicatricial pemphigoid with aqueous deficiency. And the patient was subjected to a conjunctival biopsy, which revealed C3 in the basement membrane zone. And this confirmed the diagnosis of pemphigoid in the patient. And he was advised a rheumatology consult for both IMT clearance as well as a systemic evaluation to rule out any underlying connective tissue disorders, which did not reveal anything at this point. And the patient was started on systemic immunosuppression, methotrexate weekly. And with this, there was good control of the surface inflammation and there was no progression of cicatrization. The patient had dense cataracts in both eyes and underwent cataract surgery. And this is the picture after the cataract surgery. With scleral contact lenses, the patient did well. And he was continued on methotrexate and maintained a stable CD4 count. He again presented to us after 6 months with significant surface inflammation and there were significant SPKs in both eyes. And the patient was very symptomatic. And this time he told us that he had developed joint pains in both wrists as well as fingers. So again, a repeat serology was advised, and here the patient turned out to be positive for RA. And a rheumatology consult was done with, and the patient was diagnosed to have rheumatoid arthritis. And the oral methotrexate dose was increased, and mycophenolate mofetil was added to the regimen. With this, the patient, the surface inflammation improved to a certain extent, and all 4 puncta were patent. So the patient was planned for a punctal cautery. So this is the clinical picture after the punctal cautery was done, and there was improvement not only in the surface inflammation, but also the staining. This was the first time that the patient was able to open his eyes in room light. Until then, unless the patient was wearing scleral contact lenses, the patient was not able to open his eyes, and the vision always improved only with scleral lenses. Otherwise, the patient had a vision of 2400, 2500. And this is the first time that his unaided vision also improved following the punctal cautery. So with this case, there are 3 points that I would like to highlight. One is the coexistence of autoimmune disorders. Second is the role of serology. And third is the punctal cautery. So first, coming to coexistence of autoimmune disorders, whenever a patient has an autoimmune disorder, it means that they have lost the ability to tolerate self-antigens. So if the patient has one disorder, nearly 30% of these patients are likely to have a second disorder. So just because one entity has been identified, we must not presume that the patient may not have a second disease, and this should always be looked out for. In this particular patient, the diagnosis of the patient first presented with aqueous deficiency and then later on developed cicatrization. But the degree of cicatrization was very less. And in early pemphigoid or early to moderate pemphigoid, the severity of aqueous deficiency is not very great. So if patients have early cicatrization with very severe aqueous deficiency, we must always suspect that the patient has concurrent Sjogren's, either primary or secondary. So next is the role of serology. So in this patient, initially the serology tests were negative, which then the patient had a seroconversion nearly 1.5 years later. But just like how for pemphigoid, a conjunctival biopsy adds to the diagnosis, but primarily the diagnosis is a clinical one. Even for rheumatoid arthritis, it is the type of joint involvement and the distribution of joint involvement that helps us come to a diagnosis. The serology definitely adds to this. If the patient has, especially if the patient has 3 times the upper limit, it helps conclude that the patient has rheumatoid arthritis. But just a positive serology where the values are just above the upper limit does not mean that the patient has rheumatoid arthritis, and the vice versa. If the serology is negative, it does not exclude the presence of RA. So this is particularly important for us as ophthalmologists because many times we are the physicians who come first in contact with these patients. So asking for that history, as was very nicely elicited in the previous case, of joint pains, if dryness of mouth at regular intervals, especially if there is an increase in the ocular signs, is important. And we should always get a repeat rheumat consult done when required. So getting the repeat serology, and if it is negative, we should not leave it at that. The patient can always have extraocular involvement in the form of arthritis, and getting a systemic evaluation done is just as important as the serology. Finally, coming to punctal cautery. So this is invaluable in management of patients with aqueous deficiency. So we have the option of temporary punctal plugs, and they can be considered if the patient is not very keen for a permanent procedure. But in patients with very low Schirmer's, it is better to go for a direct punctal cauterization. So this is a recent systematic review, which has very nicely described the different techniques that are involved. So usually either a Bowman's probe or directly the radiofrequency ablation probe can be placed inside the vertical canaliculus, as seen in this picture over here. And the end point is this blanching, which is visible in this image over here. So as the blanching occurs, the probe is gently withdrawn. And it is absolutely imperative to do this with good local anesthesia, because if the patient is in pain, they will not allow the punctal cautery. It will be partially done, and then the puncta will not get occluded. So this is a representative image of a patient just 3 weeks after punctal cautery with significant improvement in the surface staining. And this is a paper which very nicely describes the long-term outcomes, and they have shown that the effect is seen up to 1 year. So the improvement in the surface staining can continue up to 1 year. So you can follow up the patients closely until then. And nearly 21% of these patients will have recanalization. So even if the puncta is occluded in the initial follow-up, at subsequent follow-ups, it is important to observe if there is any recanalization. And if at all this occurs, we can again subject the patient to a repeat punctal cautery. But even if it is completely occluded, we should not presume that, we should still keep the patient on follow-up and observe if the puncta is recanalizing at any point or not. And finally, use of topical steroids in the initial postoperative period is not recommended because recanalization rates are higher when this happens. So just a antibiotic ointment is sufficient in these patients immediately after the procedure. So to summarize, aqueous deficiency dry eye, we must always look out for autoimmune disorders. Even if the initial investigations, if the initial symptomatology is not there, you should inquire about it at regular follow-ups. Get a rheumat consult done, a repeat rheumat consult done, or a repeat serology done if required. These patients should be placed on IMT when an autoimmune disorder is detected. And coexistence of autoimmune disorders can also occur, and that must be kept at the back of our mind. And punctal cautery is absolutely invaluable in the management of these patients, and the threshold for this should be very low, especially in patients who have very advanced disease. Thank you, everyone.
Thanks, Anahita. I think both with Isha and Anahita, I'm just amazed at how crisp and how informative both your presentations have been. And Anahita, there were so many important points that you covered very lucidly. And it's a good thing that this webinar is available online, because I'm sure that many people should, at least I would go over it again, because the points that you made about having, just because you have early cicatrization with features of dry eye, think about some other cause, and the seroconversion about RA positivity, which is so important, because I've seen that multiple times that patients have just borderline elevated RA. So it is like the diagnostic momentum. You have dry eye and then you have RA positivity, and then you think that it's RA. So all of these points are very, very important. And I was absolutely enthralled by your presentation. A lot of learning. Prajakta, maybe you can ask your question directly. You can unmute and ask your question, and then we'll go to the panelists, because Anahita was so on time.
Yeah, there was one of the articles by Dr. Geeta here in which she mentions that the color should turn from white to black, that is eschar formation.
Yeah, yeah. Okay, sorry.
I was just asking whether we should wait till it turns black, like the endpoint for punctal cautery to last longer, wait for recanalization.
So during the procedure, we do wait. The endpoint, initially there is a mild blanching that occurs. And when you are doing it within the canaliculus, it is not very easy to appreciate the SCR. But as you're pulling out, that is when the SCR becomes more obvious, and it is maximum around the punctum. So the only thing is, like, when you're pulling out, you should not do it very aggressively, or the entire thing will come out, and then the recanalization rate is a little higher. Dr. Geeta, do you have?
AIOS, please.
Yeah, so I think our experience with punctal cautery, especially in very severe aqueous tear deficiency in rheumatoid arthritis patients, it definitely helps. What you need to do when you're doing the cautery is we do wait for that little bit of blackening to happen. You need to remember that you need to come out with the cautery still on. So you don't stop cauterizing and then pull it. That's when it actually comes out with the tissue, and there is a high possibility of recanalization. So very, very low threshold as far as punctal cautery is concerned, and we do wait for that little bit of blackening to happen at the punctal opening when you pull out your probe.
So,
Thank you.
Himanshu, I wanted you to share your experience about patients that you also face, distinguishing between cicatrizing versus other forms of dry eye.
I I I guess this was one of the most complete presentation. There's no need for any comments from anybody. Very, very interesting thing, Anahita, where like from cicatrization to, I mean, from aqueous deficient to and having coexisting cicatrization part. That's so interesting that once diagnosed, the case cannot be left alone. That you may be dealing with some other factor which may unveil a little later on. One interesting part which may get lost in the discussion was the values of anything. So any serology, whenever we take when it's more than 2 standard deviation or triple the amount of normative figure, that's significant, and we should be certainly looking at that with total confidence. Anything which is borderline may not be very regular, but along with that, it's very important to know what kind of technique has been used in laboratory, and there's no doubt that sensitivity, specificity of each of them is very different. So looking at value alone may not be important, but along with that, whenever you are in touch with your lab person, you should be knowing that what technique they have used, what reagents they have used, and which sort of may change your decision about believing in those things. At the same time, it's very important for us to remember that any values which are abnormal ones may not always mean that they're abnormal forever. False positive, false negative are always there. So confirmatory sign was not only important for confirmation, but also important for the follow-up case where you're looking at the values, whether there are changes in value, improvement in values. So it's very important to have the serial analysis of these serology values, which we should be taking into account.
Himanshu,
In
your
previous
next-
case also we were talking about the dry mouth part, and I guess I have very low threshold when it comes to starting something like pilocarpine orally. I think am I not audible? Or?
I think for a moment you weren't, now you are.
I guess I'm not audible.
You're audible, Himanshu.
Okay, I said I have very low threshold for starting oral pilocarpine 5 milligram. I usually start with a higher dose, like 3 times a day, and then. Okay, I think we can go ahead. Just I think the presentation was very nice. I think.
So Himanshu, you're up next. If you can just share your screen. I think somebody had a comment.
Yeah, I wanted to comment.
Yes,
I want to ask the house that whether punctal cautery or occluding the punctum is advisable when you have immune-mediated dry eye. Because usually in these kind of cases, the cytokine levels are very high in tears. And I am little averse to, occluding the punctum because the dry eye sometimes goes worse in these cases.
So can I just make a comment here, Dr. Ritu?
Yes, yes.
Yeah, so we have been talking about the role of punctal cautery in these patients who have an underlying immune condition. I do understand that there has been this concept of what we refer to as toxic tears following punctal cautery because of a buildup of the inflammatory mediators on the surface, which sometimes further tends to worsen the ocular surface. But in patients with very severe aqueous tear deficiency, in most instances, the inflammation is secondary to the very severe dryness itself. If you are concerned about it, you can occlude the punctum temporarily before you actually take up the patient for a cautery.
That's what I normally like to do.
Yeah, but in our experience, where we have cauterized almost close to, I mean, 500 plus eyes of 250 patients with rheumatoid arthritis with severe aqueous tear deficiency, there was a significant improvement in their corneal staining, the Schirmer's as well as the visual acuity because of the resolution of the epitheliopathy.
But were they getting topical steroids also along?
Not at all. In fact, our threshold for using steroids, we generally prefer not to use topical steroids. Punctal cautery features lower down in our step ladder approach to management of aqueous tear deficiency in these patients, and steroids is reserved only if the inflammation still continues to persist after the cautery, because in most of these eyes, the inflammation significantly improves post the cautery. But I do know
experience of using topical cyclosporin.
If I can
Yeah,
just,
okay.
we'll come back to this because we have same things in the panel also. And we'll go to Himanshu. And Bhaskar, are you there? I want you to be attentive for this presentation. It's something that you would like.
Yeah, I'm there.
Okay, great.
Can I put in a word, please?
After this presentation.
Okay.
Yeah. Please go ahead, Himanshu.
Oh, good evening. Thank you, Somshila and AIOS for giving me this opportunity. Am I audible and my slides are visible?
Yes, please.
Okay, fine. Thank you. Okay. So I start with, so I'm going to present 3 simple cases and I'm going to give a simple message to our August audience and convey a few simple things which we may miss out in our clinical practice. I do not have any financial disclosure. So I start with first case where a young lady who is a housewife, 27-year-old, present to us with redness and irritation since 1 week. And this is the clinical picture. Right eye does show a diffuse congestion. Left eye relatively is quiet. Right eye temporally also there is a focal congestion which is seen. Both eye vision was 6/6 and 6. There's no pain, no discharge, no itching, no vision loss, nothing at all, no anterior chamber inflammation. And when I ask further about the history, typically whenever we look at the cases, we never take the history in the beginning, or rather it's not possible to take the complete history like that. And that's where the back and forth history taking is important. When you see a case, you go back to ask particular history to the patient. So asking about the history of redness, and patient said that there is an on and off redness in either eye since almost a year. Now, probing further, patient said, well, it's better in the morning, but she gets tired by afternoon and then she just wants to close her eyes. And it's that's a very important thing to remember. Just keep in mind this part. Next, she was worked up earlier for her problem, and there was no systemic illness. She was not on any medication. Serology was normal. Thyroid profile was normal. And finally, when I asked, she did say that there was eye flu history in her family before a year, and following which all these things had started. On the examination, most of the things were normal in both eyes, except when we look at the conjunctival part, there was a diffuse bulbar congestion in right eye. There was velvety upper tarsal conjunctiva in the right eye, and the left eye showed papillae on the UTC, as well as there was blanching and some mucosal scarring in upper tarsal conjunctiva in the left eye. There was a focal congestion in both the upper bulbar conjunctiva in both eyes, right eye a little more than the left eye. The rest, everything was absolutely normal. Schirmer's value was within normal limit. So with this thing, well, it becomes difficult. So we stained the patient, and when we look at the fluorescence staining, nothing much on the fluorescence staining except the left eye, which showed those concretion kind of features, and some amount of staining of upper tarsal conjunctiva in the left eye compared to right eye. Mind you, the congestion was more in the right eye this time. However, with this thing, when you do something else, where you start with what Geeta was talking about, barrier filter, yellow barrier filter, and that's where magic happens, and that's where you start seeing invisible things. You start seeing that the right eye upper tarsal conjunctiva had significant amount of septate scarring. You start seeing that the upper bulbar conjunctiva of right eye had diffuse punctate erosions. Also, the cornea had one filament there. The eye, which was relatively quiet, left eye, you could actually notice that there are a significant amount of upper tarsal erosions. Same way on upper bulbar conjunctiva from 10 o'clock, 2 o'clock region, there is significant amount of punctate erosion. And this was a case of superior limbic keratoconjunctivitis, most likely due to adenoviral conjunctivitis, which led to the scarring in UTC, and that led to the mechanical factor, which was responsible for the superior limbic keratoconjunctivitis here. So if you look at what we were missing out, we were missing out on the significant findings which were there on upper tarsal conjunctiva. We were missing out on significant findings which were there in upper bulbar conjunctiva. Also on the entire ocular surface staining, which we could not appreciate had we not used the yellow barrier filter. So, well, with the left eye showing that significant loss and blanching of upper tarsal conjunctiva, we did a meibography. But remember here, whenever there is a significant amount of subepithelial scarring, sometimes meibography may be abnormal. And if you can see here, you can actually visualize few of the meibomian glands, and which may be related to the scarring may mask the meibomian glands. So just don't think that there is total loss of meibomian gland here. Right eye meibomian glands were absolutely normal. So patient was treated with topical anti-inflammatory, because remember, when there is significant inflammation, which is related to either the mechanical trauma or the inflammatory trauma, you do need anti-inflammatory in terms of topical steroid. Surface steroids are pretty much fine here. Along with that, non-steroid anti-inflammatory, here we use cyclosporin, but whatever suits you, you can use. Wherever there is a significant amount of ocular surface damage, a preservative-free formulation can always be preferable versus a preservative formulation. The lubricant here could have been a preservative-free lubricant, whether sodium hyaluronate, which reduces the shear rate and mechanical trauma. But along with that, one most important part, if I have to give you only one medication, that would be a paraffin-based ointment at the night. Now, that does significantly improve the friction-related trauma, and patient becomes much more comfortable clinically. Remember, these cases where there is a trauma which is related to previous scarring, an MMG can certainly be of help. Not all the cases of SLK, MMG should be considered or need to be considered, but here in this case, it can be certainly of help. Coming to the second case, now we are dealing with a colleague from my campus, a cardiologist, who comes to an OPD in the afternoon, said significant irritation, discomfort in both eyes, left eye more than right eye, uncomfortable since morning, could not focus while operating, but in the afternoon, by afternoon, he couldn't operate and he came to the OPD. He said that he had previous episodes of similar thing in past, and he was a known case of thyroid dysfunction on irregular treatment, like most of the physician and doctors. As you can see from here, this case does show there is significant amount of UTC papillae, and we can actually see focal congestion in the upper bulbar conjunctiva involving limbus, also thickening of limbus, and this. There was no doubt, but we were dealing with superior limbic keratoconjunctivitis. Now, from here, we can see that, again, barrier filter fluorescent staining does show significant amount of punctate erosion and mechanical erosions on the upper tarsal conjunctiva as well as the upper bulbar conjunctiva. Not only this thing, patient had, so this was a case of superior limbic keratoconjunctivitis, most likely with thyroid ophthalmopathy. Along with this thing, he had something which we could actually diagnose with fluorescent staining, and that was nocturnal leg ophthalmos. We know that nocturnal leg ophthalmos can worsen the dry eye symptom, and these nocturnal leg ophthalmos patients usually have worsening from the morning, and later on, when the day passes, they improve. But interestingly, SLK worsens when the day passes, and nocturnal leg ophthalmos is worse in the morning. So that's the reason why this person had problems since morning and not just afternoon. Now, interestingly, we with the simple fluorescent staining alone, we could actually visualize a small amount of nocturnal leg ophthalmos, which was hiding behind the eyelashes. And that's another important part of fluorescent staining, which you can utilize. Along with this thing, we could also see the incomplete blink in this patient. And as you can see here, tide line, the black color lines which we see, which shows us the previous blink and where the previous blink stopped, and can actually tell you the story about incomplete blinks also. So that's another important part of a simple, humble fluorescent staining, which can show you along with a yellow barrier filter. So he was advised to consult an endocrinologist along with previous case what we discussed, the anti-inflammatory. Now, in this case, I wanted to give him tacrolimus topically, preferably, because the amount of inflammation what we had was much more severe because of the thyroid dysfunction, and topical lubricant preservative free with the gel, and of course the paraffin based ointment at the night at the lid, along with the lid taping was advised. An oculoplastic opinion was sought, and he was treated with all these things with a significant improvement in the follow-up.
Almost out of time, Himanshu. Almost out of time. You can wind up.
Okay, so this was one of my colleague. Again, similar symptoms.
Oh, okay. So I would stop you here, Himanshu. I'm sorry, because we're out of time. And either if you could just very quickly summarize the case just to the basic point of the case, because it's already 10.5 minutes.
Okay.
So
what we let's take that what we can normally miss out on things which are which if we are not using the barrier filter, Shermer's test may not be the best thing. I would possibly finish this thing with the video of how to do fluorescent staining. The most important part of staining is the amount of stain which we use. I guess my video is not running here, but it's very important for us to remember that it's a very small amount of fluorescent which is required, and otherwise there would be quenching, and you may not have the proper staining. A small amount of stain means a small drop of preservative-free antibiotics such as moxifloxacin. Remove the excess stain on your filter paper or your sterile swab, and then put it on the eye. Just gently touch on the lower palpebral conjunctiva, and that's more than enough. I think we can take up rest of things in discussion.
Sorry about that. So I was asking Bhaskar to pay attention to this, because what Himanshu has beautifully demonstrated is the use of fluorescein and how he's unveiled the 3 different cases with 3 different different pathologies, not just SLK, but much more than that. Is Bhaskar there? Bhaskar, you connected?
Yes, I'm there. Very nicely shown the fluorescent stain with the barrier filter. Often we don't use the barrier filter, so we see only half the issues. So in the first case that Himanshu showed, the subconjunctival fibrosis resulting out of the adenoviral conjunctivitis. So I think we should have a low threshold for use of steroids in early adenoviral conjunctivitis, because otherwise we tend to see these complications much more. Although the classical teaching is to wait for the viral conjunctivitis to subside on its own, but the damage that is done is of a semi-permanent in nature. So personally, I would have a low threshold in starting steroids. And from the first case that was presented, if you see that usually for surface inflammations, chloromethanolone or loteprednol suffice. We do not need prednisolone acetate, and we do not need to face the complications of predacetate that we see, like rise of IOP and cataracts, etc. In surface infections, fluoromethalone alone works very well.
I just
So
had a
Dr.
question.
Namrata has also joined it.
I just had a question for Himanshu. Himanshu,
Yeah.
how, if you did do a MMG in your case, number one, what would be the interval between, the acute episode getting over and then you doing your MMG? I just thought MMG was a little overkill for subepithelial fibrosis that occurs after adenoviral keratoconjunctivitis.
Yeah. Thank you. I didn't do MMG. I said that we
Can be
can
done.
do MMG in selected cases where it's mechanical factor, which is scarring, which leads to such kind of thing. So we can do, so normally superior limbic keratoconjunctivitis, surgical treatment is not the treatment of choice, and they do respond well to the medical treatment. But when it's a scarring, when it's a mechanical factor, and especially the scarring kind of factor on upper tarsal conjunctiva, there can be role of MMG. I didn't do MMG in this case. What I was describing, this kind of case where there is a scarring which is the culprit, you can possibly have MMG. When the case which is related to the mechanical trauma, related to tight lid, related to proptosis, MMG would not be the important thing. When there is idiopathic case, like third case I was talking about, MMG does not have any role. So the role of MMG is only in such cases where there is related mechanical trauma related to scarring.
So Himanshu, in a
Part which I would
nutshell,
like to convey in most of the cases of superior limbic keratoconjunctivitis, typical presentation of patient giving a history that by afternoon I am absolutely pathetic. Morning they are usually very, very fine, and by afternoon they are quite symptomatic. Any person who says such kind of thing, please lift the upper lid and look for any superior congestion.
Thanks, Himanshu. You read my mind and give us a gist of what we need to look at, the most important thing in SLK. So excellent so far. And those of you who feel that you're not getting time to ask or to put forth, I know we have so many specialists here. We have there's not enough time to have everybody's comments, unfortunately. We'll move to dry eye disease. Over to you, Purvasha.
Yeah, a very good evening to everyone. And this is, I would like to thank Dr. Somashila for making me a part of this dry eye disease webinar. So this is basically a more in-your-face kind of a dry eye disease case. So it is more of a exposure keratopathy that we all might have been exposed to. So this is the story of a 54-year-old female who is a resident of Madhya Pradesh and was referred to us from the neurosurgery department in August last year for diminution of vision, recurrent redness, watering pain in the left eye since 10 days. She also had a history of having a hydrocephalus along with a cerebellopontine angle tumor, along with hemicranial headache, sensory neural hearing loss, vocal cord paralysis, and imbalance. She had a ventriculoperitoneal shunt in situ, and she had been operated for the tumor in July last year. And this was 2 weeks post-operative, and the diagnosis was vestibular schwannoma or the acoustic neuroma. There were no similar complaints in the past, and she has no other significant personal or family history. She is a conscious cooperative female with stable vitals, and higher mental functions were normal. However, she also had multiple cranial nerve paralysis. So there was a profound sensory neural hearing loss on the left side along with a vocal cord paralysis. The rest of the systemic examination was okay. Coming over to the visual acuity, 612 in the right eye and finger counting close to face in the left eye was a distance vision. And this is the clinical picture in her eyes. This is basically showing facial asymmetry with the loss of forehead wrinkles on the left side. There's no proptosis as such, but there was abduction restriction in the left eye. No nystagmus of any sort. On closure of the lids, this is her picture where there is lag of thalamus with an incomplete closure of more than 10 millimeters with an incomplete blink. Bell's phenomenon is poor. Conjunctival hyperemia and chemosis was present. Sensations were slightly decreased on the left side. There is an epithelial defect of 5 by 6 millimeters, along with an AC reaction and a streak hypopenia over there. I'm sorry, I don't have a fluorescein stain picture over here. Their pupillary reactions were normal. Her left disc margins nasally and the disc margin nasally was blurred. The intraocular pressure was normal. The tear meniscus height was slightly raised, and the Schirmer's was good enough, 15 millimeters without paracrine. So, a diagnosis of left eye exposure keratopathy due to paralytic lag of thalamus, due to the facial nerve palsy following vestibular schwannoma surgery, along with other cranial nerve involvement, was made. And because the cornea was at risk of melt and perforation, so we advised her frequent lubrication along with nighttime lubricant ointment, along with a topical antibiotic and epithelial-friendly chloramphenicol ointment, and cycloplegic agents were advised along with eyelid taping while sleeping. And she was posted for an left eye temporary lateral tarsorrhaphy. The neurosurgical management in the form of anti-epileptics and other post-operative medication for her surgery were continued. So this was post-operative picture after the lateral tarsorrhaphy, where the palpebral fissure was decreased. However, in the meantime, we had also done some nerve conduction studies, and which showed that the compound muscle action potential was reduced for the left side for these muscles, left frontalis, orbicularis oculi, nasalis, oris mentalis, and the blink reflexes were also affected. So these were the motor nerve potentials. There was the direct laryngoscopy done, which showed the left vocal cord paralysis, along with audiograms showing profound sensory neural hearing loss. So we were trying to manage her. This is the Ral's tube intact in situ because of the inability to swallow properly and to prevent any aspiration. And somehow, within a week of the tarsorrhaphy started becoming loose, and the ocular surface again destabilized. The streak hyperpain increased, and the epithelial defect again was not resolving. And this is the fluorescein stain picture. The tarsorrhaphy was redone, and there was this again this over a period of time, over the next 1 or 2 months, she healed. The epithelial defect started responding. The 6 months post-operatively, it had healed. There was mild scarring and thinning present. But this was the last follow-up picture a month ago, and she is maintaining a good surface right now. There's pooling of the dye there, but otherwise the tarso has given away. But yes, we will need to redo it again. I'm just keeping her up on a follow-up now. So just coming over for a general discussion, acoustic neuromas form the 8% of primary adult intracranial neoplasms, and they arise from the vestibulocochlear or the eighth nerve. And usually they have, if they are benign and they are not very fast growing, then there is a wait and watch policy. Otherwise, they are taken up for stereotactic radiosurgery or surgical resection. And because of the proximity of these nerves, the eighth nerve, the seventh nerve, along with the fifth nerve, so while resection, these tumors can lead to damage to these nerve roots, and these again lead to various neuroophthalmic manifestations. So here again, we had the fifth nerve involvement as well as the sixth nerve involvement, which could also be taken up as a false localizing sign when the intracranial pressures are high. So there was no presence of a beating nystagmus, which again would signify a vestibular dysfunction, and there was slight papilledema present, early mild papilledema present, which resolved later on. So paralytic lag of thalamus due to neurosurgical lesions and surgery can be a long-standing ocular surface disorder and needs to be looked into with proper follow-ups and compliance. And the spectrum of treatment will include anything from copious lubrication, moist chamber glasses, taping the lids, along with temporary and permanent procedures. There could be gold weight application or Botox, tarsorrhaphy, or tightening of the lid. And if there is a presence of ectropine also, then we need to go ahead with the ectropine correction or a lateral tarsal slip surgery. So I think these are the key points. A close watch from the ophthalmology side post neurosurgery is needed. And lag of thalamus does need continued treatment, and timely intervention will prevent further corneal damage, which is expected in these chronic patients.
Thanks,
Thank you so
Purvasha. Purvasha, you sounded a little apologetic about the whole case, but I think you achieved a fantastic outcome for the patient. So that we.
I'm not sure if I can hear them.
Am I audible?
Ma'am, light चली गई है.
Am I audible?
Yes, Dr. SS, you're audible.
Yes, you are audible.
Oh,
Yeah,
okay,
you are
thank
audible.
Yeah. All right. So I think Purvasha presented a fantastic case where the outcome was extremely good. And these kind of cases we do see in, especially those of us who practice in hospitals apart, which have all multidisciplinary hospitals. So I'd asked Dr. Ritu and Dr. Namrata to talk about such cases which they may have come across as well. Dr. Ritu.
So I think Purvasha did, actually electricity is not there. Anyway, Purvasha did show a very good case, and we do come across such cases, especially when you are a part of multi-speciality hospital. These cases are difficult to manage. There is Purvasha.
Ma'am, I'm muting.
Are you three in the same room also by
We
any
are
chance?
sitting in the same room, actually. That
Okay,
is.
fine. Yeah, so Purvasha, yeah, please. One of you will have to mute. I was just going to say that.
So I think these are very difficult cases, and these really have to be managed. And I think Purvasha showed how these cases can be managed. These are tricky cases because they will not, the eyes are not going to close. And then there was this question whether we can use bandage contact lenses in these cases. And I think bandage contact lenses should not be used in these cases because they anyway have a compromised ocular surface, and also because of the fact that the secretions they get collected in the conjunctival sac, and also because of the fact that these corneas may be also anesthetic. So if they do have some evidence of infection, or if they do have any problem, the patient is not going to come to know about it also. Dr. Ritu is there. I think she can also give a comment on this.
Yeah.
No, I agree with whatever way you presented and how they managed it. They managed it very well. They are very tricky cases, difficult cases, because a lot of time multiple nerves have gone, and even tarsorrhaphy doesn't stay for longer period.
So Sain,
I'm having internet issues, so maybe my voice might break.
So Sain, I thought you were going to comment on this case, and I know that we also get our fair share of such cases at LVPI.
Like you said, I think the case was very well managed, and Bhaskar did a really good job of taking care of it in a comprehensive way. But yes, tarsorrhaphy is very critical in these cases, neurological cases where there's exposure in lagophthalmos. And I think obviously this patient will require a permanent paramedian tarsorrhaphy, so that needs to be put into place. Otherwise, because there is some amount of neurotoxicity and there's also lagophthalmos where keratopathy will keep recurring. So that needs to be obviously
there were two additional points that I thought that one was about the use of bandage contact lens, and I'm not averse to using it in a given situation if I can control other things about the patient, that he's not in ICU or something. If it's an outpatient who's able to come in frequently for follow-up. So I would use a bandage contact lens as one of the treatment. And if it's very bad, then we also do amniotic membranes for these patients, as was mentioned by someone, I think. The only thing about, that when you have that very severe lag of thalamus and you do a lateral tarsography, you still have a significant amount of exposure. It's still exposed and it still doesn't close well. So I think there is a variation in the tarsography and how it's done, which is what Prajakta is asking, I guess. So which tarsography is preferred? Anybody would want to go with that, Geeta or anyone else?
So it is essential that you do a good a lateral tarsography is not just the lateral 1/3. You might have to start from beyond the center point, extending up to the lateral. A paramedian also, what Simon was mentioning, does help to close the surface better. So sometimes you might have to add on or extend your extent of tarsography based on the outcome that you will get. So it will have to be a good tarsography that you will have to provide in these kind of cases.
I think sometimes you have to almost completely close it except for a little chink that is there. And in that chink, you can actually instill fluorescein and then ask the patient to move the eye up and down so that you can see, what is happening to the exposure keratopathy. Because like I said, if you do have, because of neurosurgical problems, anesthetic corneas, then it is a recipe for disaster.
Yeah.
Right. So this, I think
sometimes I've done multiple. I've done medial and lateral tarsography also.
Right. So medial and lateral. So before Ikeda starts, I think Sayan had put a very important point in the chat box. Sayan, if you can, this is the point about using the term post-adenoviral, and that's a very important thing which I think I at least have learned from Sayan only about other viruses. Sayan, could you please elaborate on this?
I just wanted to mention that there are a lot of different conditions which can cause post-conjunctivitis sequelae, including aqueous deficiency. These are post-infectious and also immunological sequelae of conjunctivitis, but they are not necessarily adenoviral. Like, for example, last year we had this, or I think last year or year before, we had this epidemic conjunctivitis, but it wasn't adenoviral. It was, later on when the genotyping was done, we found out that it was enterovirus. So a lot of these, it's not necessarily adenoviral. It can sometimes be mycoplasma as well. So I think post-acute conjunctivitis sequelae or post-infectious, post-conjunctivitis sequelae is a more appropriate term than using adenoviral, which is a microbiological diagnosis, which we really don't do. It's a clinical diagnosis. It's not really we were not really doing any kind of diagnostic test to confirm this adenovirus. So we tend to give adenovirus too much credit.
No, that's there. But Sayan, the management will not change whether it is adeno or entero. I think it remains pretty much the same.
Yeah, I guess these are one-time episodes which tend to leave behind these kind of cicatricial sequelae, which leads to the aqueous tear deficiency. So yes, the semantics of the nomenclature apart, the management would continue to remain the same.
I mean, in mycoplasma, it would differ. If it's any other
Mycoplasma
virus.
is a totally different entity that we're talking about. That is an atypical Stevens-Johnson syndrome kind of a picture that leads to cicatrization. So what we are referring to here is more of the one-time conjunctivitis-like episode that leads to these kind of conditions.
Supriya, you could ask your question before we go on to Ikeda's presentation.
Yeah, thank you, Dr. SS. So I just wanted to ask how do we prevent exposure in patients who have lag of thalamus secondary to, any kind of orbital floor repair, especially patients who have oral cancers and who've undergone maxillary surgeries, where the entire globe is, slightly dislocated, like subluxated downwards because of the orbital floor defects that have been created following maxillary surgery. So how do we really, because there even tarsography
tasseraphy will not be beneficial. So, I mean, I would like to ask anyone who has had any kind of experience with similar case.
So I think their tasseraphy may not help, but amniotic membrane would, because that can still cause, the coverage of the ocular surface. And I think you have to rope in your oculoplasty person definitely in those cases.
Okay. Thank you.
So I'd like to welcome Ikeda Lal, who's waiting for a long time to present her case now. And she's also going to cover Sjogren's syndrome, but it's very important to cover this today.
Very good evening to all, and thank you, Dr. Somshila, for making me a part of this wonderful webinar on dry eye. And I'll be talking about Sjogren's syndrome and dry eye. So my first case is a 57-year-old female patient. She complains of intermittent irritation and redness, which is associated with blurred vision in both her eyes. She's more symptomatic in the left eye than the right. And this has been going on since a year. She has been on and off on tear substitutes. There is no past history of any ocular surgery or trauma. She does give history of occasional dryness of mouth and the need to frequently drink water, and also gives history of associated dental cavities for which she has undergone interventions. There is no history of stiffness of small joints and no history of skin rashes or repeated mucosal ulcerations. So systemically, she is being diagnosed as a hyperthyroidism, and she is on 50 microgram of levothyroxine for the same, and she's also on rosuvastatin for cholesterol. There's no significant history of any medication used for anxiety or allergies, and no significant history of any surgical procedure. So this is at presentation. Her best corrected visual acuity in the right eye is 20/60 and left eye is 20/80. And when we examined her, we could, I don't have the pictures of the fornix, but there was no significant cicatrization. There is some amount of congestion of the conjunctiva, as we can see. And when we stained her and examined her, we can see these interpalpebral SPKs, which are very evident. The left eye, she was much more symptomatic, and therefore we had to decrease the illumination to capture the pictures for the left eye. And here I would just like to share these two films that we had documented, and this shows us the tear film staining very beautifully, and to look at her tear film status. So we can see that there's a nearly complete blink, and as soon as she opens up her eye, there is almost instantaneously, within 1 to 2 seconds, there is a tear film breakup. So this again is important for us to do, and as highlighted earlier, that this filter really helps in visualization a little bit better. Her Schirmer's was 8 in the right eye, 8 millimeters, and 6 millimeters in the left at 5 minutes without anesthesia, with eyes closed. She also had significant cataract in both the eyes and had an ERM in the left eye. So given the clinical picture, clinical diagnosis of aqueous deficiency dry eye was made with the probable underlying primary or secondary Sjogren's syndrome. And she was advised to go for a rheumatology referral to diagnose primary or to look for causes of secondary Sjogren's syndrome. And typically, these are the tests that the rheumatologists advise, which is including a complete blood picture, ESR, CRP, rheumatoid factor and anti-CCP antibodies to look for rheumatoid arthritis, since it is most commonly associated with secondary Sjogren's syndrome, an ANA profile to look for SLE, and anti-Rho and La antibodies to look for primary Sjogren's syndrome, along with a thyroid function test and serum ACE. So topically, she was started on CMC 1% eye drops 8 times per day, HPMC 0.3% eye ointment BD, and she was also started on cyclosporin 0.05% 2 times per day, along with fluoromethalon eye drops in tapering doses. So she came back after the rheumatology consult. They did not find any underlying autoimmune disorder, and she was anti-Rho antibody positive. All cases of primary Sjogren's might not be, but it was easy for us to establish a diagnosis in this patient because she did have serology positive for Sjogren's. And the rheumatologist did not start any immunomodulatory therapy, but she was started on oral pilocarpine. This is just to highlight the criteria that is used by our rheumatology colleagues to diagnose primary Sjogren's syndrome. So basically, either serology positive or positive salivary gland biopsy are the two main criteria which have the most scores in this classification, which are used for diagnosis. This is at 1 month follow-up. She is symptomatically better, and the surface looks definitely a little bit better, especially so in the left eye, which was more advanced, more involved than the right eye. So she was followed up over a period of time, and at 6 months follow-up, the patient is symptomatically stable with a stable ocular surface. And at this point, we planned cataract surgery, and I did start her on perioperative oral steroids because she had on and off inflammation for which she did require fluoromethalon eye drops. And she was counseled for increase in symptoms of dry eye after cataract surgery. So I would just highlight the precautions that we take in these cases of Sjogren syndrome when we are taking up a patient for cataract surgery. So going ahead with the microincisional surgery and phacoemulsification rather than SICS, and avoiding any other incisions in the eye. Also to limit the drop exposure, especially the topical anesthetic eye drops before preoperatively, and also preoperatively and postoperatively NSAIDs, and prescribing preservative-free drops more for these patients, especially when we are looking at antibiotics. During the procedure, to limit the ocular surface drying, coating the ocular surface with the dispersive OVD comes in more handy than repeated irrigation with BSS, and makes us more comfortable during the surgery. And just a word about the exposure when we are using a microscopic illumination. It helps to increase the retroillumination and decrease the direct illumination. That makes the patient more comfortable as well. When we are dealing with these cases, especially even any dry eye case, to avoid the conjunctival trauma, we can avoid using LIMS forceps and also taking extra care of the epithelium during the procedure. So this is just a short video of the cataract surgery. So here I'm using a chopper rather than holding the eye with the limbs, and then going ahead and coating the ocular surface with a dispersive OVD before I start to prevent ocular surface drying, and using a 2.2 millimeter incision. And this is just to highlight the use of retroillumination, which also increases our visualization during the procedure. And again, coating the surface repeatedly with dispersive OVD helps. So this is 6 months after the cataract surgery. The visual acuity is 20/20 in the right eye with 20/30 in the left. She is being maintained on tear substitutes and cyclosporin 0.05%. And the Schirmer's one now without anesthesia is 10 millimeters in both the eyes at 5 minutes. And these are our 6 months post-cataract surgery photographs. And we can see that the staining has improved, although there are still a few SPKs in the left eye. So at this visit, we decided that we should also look at her lacrimal gland. So directly looking at the palpebral glow of the lacrimal gland again helps. We can see it's slightly flatter, and I could not really appreciate significant tear secretion. Now, my second case is that of a 52-year-old female who presented to us with chief complaints of blurred vision, pain, and redness in the left eye, and she's been symptomatic for the past 15 days. She also has history of right eye being undergoing a keratoplasty, which was performed elsewhere 2 years ago, and there are no records available, but she did say that she had an ulceration in the eye for which they had to perform a keratoplasty. There is already history of associated rheumatoid arthritis, but the patient has been not compliant with the treatment, and she has stopped her all her treatment 6 months ago. So here I would just like to highlight and talk about her left eye. Her visual acuity is 20/40, and we can see here that she has this epithelial defect 1 to 2 millimeters in size. And there is also associated dry eyes is visible by the ocular surface staining. So here, this is for her left eye. Actually, she has a peripheral ulcerative keratitis, which is associated with aqueous deficiency dry eye, and the underlying cause being secondary Sjogren syndrome because of her rheumatoid arthritis. So here we counseled her and made her understand that she needs to undergo a rheumatology referral and she needs to restart her immunomodulation. And the rheumatologist started her on methotrexate 15 milligram per week along with folic acid supplementation and oral hydroxychloroquine 200 milligrams per day. So it is very important for us to make these patients understand that their ocular manifestations are related to the rheumatoid arthritis, and they require repeated counselings because they tend to on and off stop their treatment. Topically, she was started on a PG and HP-GUAR combination 6 times per day along with HPMC, and both eyes cyclosporin eye drops. Left eye, she was started on prednisolone acetate eye drops and weekly taper under the cover of preservative-free moxifloxacin eye drops for a week. So this is at 5 days follow-up. We can see that the congestion has gone down, and the PUK has nearly almost healed with some amount of staining preserving. So she was again, counseled to continue the systemic immunomodulation and not to stop it, and keep on following up with us as well as the rheumatologist. And we maintained her on lubricants as well as cyclosporin, and the topical steroids were eventually tapered and stopped. So here I would just like to highlight the importance of diagnosing secondary causes of Sjogren's syndrome. So Sjogren's syndrome can be primary or secondary, and primary does not have any underlying autoimmune disorder, and mainstay of therapy may be topical, and these cases may not need systemic immunomodulation until unless they have extragranular involvement. Whereas secondary Sjogren's syndrome, the most common causes being RA and SLE, and the mainstay we also need to look at is systemic immunomodulation along with topical therapy. Therefore, we need to work hand in hand with the rheumatologist and diagnose these cases on time, because lots of times these patients can first present to the ophthalmologist rather than a rheumatologist.
Can you summarize?
Yes, that's my last slide.
Thank you. So great case once again, Nikita, and excellent presentation. I know that almost all the panelists here are operating and extremely good surgeons in cataract and dry eye. But I'd like to ask Himanshu for, in addition to the tips that you talked about, Himanshu, how do you, when you are planning cataract surgery for your patients, and you could put in Webber's question also, how do you manage with the keratometry? And Nikita, thanks for making our session glamorous by showing one surgical video of cataract surgery. Very well done. Himanshu, over to you. What else do you do when you operate on these patients for cataract surgery?
Yeah, so pre-op, intra-op, and post-op, all three perioperative management is very important. She rightly said that before doing the surgery, you want to make sure that surface is stable to have a reliability of your parameters, which are especially the curvature parameters which you are looking at. We surely want to avoid IOLs which are possibly not best in such scenario like multifocals and those kind of lenses. Intraoperatively, of course, we would want to reduce any surface related damage, and she beautifully showed that how she coated the surface with viscoelastic and she didn't handle the surface much. Toxic things exposure on the surface post-operatively can be reduced by giving them relatively safer preservative-free medications. And with that, of course, we do continue the systemic treatment which patient is on, which keeps the surface much more better under control.
Yeah, Dr. Namrata had published about using copious viscoelastic on the surface, but that was for cornea cases, I think. But is there something different you do for dry eye, Dr. Namrata? I don't know if she's logged in. Could any of the other panelists, perhaps Sayan?
Yeah, I think, what Ikeda mentioned, he covered most of the things. I think using dispersive OBD to coat the surface is very important. Using preservative-free lidocaine instead of proparacaine, which contains BAK for topical anesthesia, is also very important. And in severe cases, you can also consider maybe at the end of the surgery using a bandage. Contact lens retroillumination helps, using trypan blue to stain the capsule to improve illumination in some cases, using of a light pipe in cases which have severe keratopathy, that helps a lot as well. So all of these things are quite useful.
And don't change your phaco machine that day. Don't let them give you another one. Use your equipment that you're used to.
Absolutely. Unless they give you a better one.
Unless they give you a better one. About the keratometry, I'm a little philosophical in the sense that more or less you will get accurate biometry. You may not be absolutely on zero target for zero, no glasses kind of target. But I think that we shouldn't really fret too much because we are not going to plan for toric IOL or something like that. So as long as we do repeated biometry and we are fairly certain that the ocular surface is reasonably okay, it'll never be perfect, but we will get a reasonably accurate. Okay, that's my way of looking at it.
Maybe just put a lubricant drop before you start doing a
That's the most practical way. Yeah. Is
Well,
that what you did, Nikita?
A few recent publications telling about the role of swept source OCT based devices being more reliable in such cases. compared to the devices which rely on placido disc, considering the tear film irregularity. So just wanted to ask regarding your experience regarding these devices.
That's
No,
a
I have
good
not.
point. But these are not really accessible to the general ophthalmologist. So we are looking for something that is practical for everybody to in this house to use, and in a simple way how to get reasonably accurate keratometry. So I think the very practical tips that were provided by the panelist will really help for the
So
patients.
it would be a good idea to have the keratometry done on two machines of different technologies like AutoK and OCT-based keratometry, or the ones that are done by the optical biometers. So maybe two sources and you can have a better tally.
So
One
I
more
cannot.
point. Yeah, sorry.
Sorry, please go ahead, Bhaskar.
No, the other point was that in these cases, I would walk an extra mile to get the ocular surface as stable as possible.
Right,
I
exactly.
would certainly consider use of tacrolimus and the use of autologous serum for about 2 months before I go in for cataract surgery.
Yeah, I cannot recall, and I'm sure everybody who's operated on these patients won't really recall a patient who's way off in terms of biometry, because you did a very inaccurate, grossly wrong biometry. So they're more or less close to target in these patients. So I don't think it's such a big a problem for accurate enough biometry. And there was one more point which I wanted to make, but I forget. So sorry. So we have, last but not the least, presentation coming up. Samrat, if you can share your screen and.
Sure. Thanks, and thanks to AIOS for this opportunity. So I'll be speaking on systemic drug-induced dry eye disease. So let me make it full screen and set my timer, because we have been very particular about that. So my timer is set, and so there are multiple classes of systemic drugs, and all these classes of systemic drugs, they cause dry eye disease. So I'm going to talk on 4 of those. So the first one was a couple of months back. Before he presented like this, he came one day with sudden reduction in vision in both the eyes of 4 days duration, and there was a lot of foreign body sensation, watering, and he was very anxious and agitated. And as you can see on these slit lamp photographs, there's diffuse ocular surface inflammation, and there's very dense SPKs, but there's no corneal edema, no AC inflammation to explain, the symptoms, but there was a significant ocular surface change. And then what was revealed was that though he had multiple systemic comorbidities like diabetes mellitus, hypertension, coronary artery disease, and a benign prostatic hypertrophy, which had made the cataract surgery really challenging, he had recently been diagnosed with Parkinson's disease and had been started on amantadine 100 milligram twice daily. So we made a presumptive diagnosis that all his ocular symptoms were actually due to this amantadine, and so we advised his neurologist to discontinue that. We advised for lid hygiene, and also we advised for carboxymethylcellulose 1% preservative-free eye drops around 6 to 8 times daily. And within a couple of weeks, there was significant improvement, and his vision was restored. And you can see in the slit lamp photographs that the ocular surface damage that had happened had actually reduced. Now, amantadine causes 2 kinds of corneal problems. One is it causes corneal edema. And in fact, in this case, there was no corneal edema because we had done an OCT, and the OCT was actually, the stromal edema wasn't there, but you can see in the epithelial map, there was significant epithelial thickness had increased, and which over time it had reduced. And amantadine causes this because it causes deposition of phospholipids within the epithelial cells and leads to a lot of cell toxicity. There are other mechanisms also, and also in very elderly patients, they would be associated ocular lid comorbidities like existing MGDs, reduced tear secretions, and reduce blink rates, especially in patients with Parkinson's disease. So these are a couple of multiple factors, but what we really did see was that by withdrawing the drug and by treating the patient with artificial tears, especially which are using either unims or they are soft with soft preservatives, then you can get very good results. So moving on to the second case. So this was a 33-year-old female homemaker who had been having symptoms of eye fatigue, foreign body sensation, dryness, watering, heaviness, sometimes itching on and off for 2 years. So when we did a dry eye test, we found that the TBUT was less and the pattern, there was random break. Since last couple of months, I have been actually focusing on the pattern of TBUT. The Shermer's test and the tear film height was okay. So patient did not have reduced tear secretion, but patient had significant, significant meibomian gland disease, had telangiectasia, blocked orifices, had meibomian blockages, and the meibum fluid was also turbid. Though so this is meibography. We don't have a fancy equipment, so we borrowed our retina colleagues this fundus camera, and it had a red-free setting. So you can see that the meibomian glands are not, there's no dropout as such. And when we took a history, we found out that patient had endometriosis for last 8 years. And since then, she has been taking this injection leuprolide, which is an anti-androgen treatment that she has been taking for her endometriosis. So anti-androgens are, androgens are very important for the health of the meibomian glands and for the, patency of the ducts. And any deficiency of that leads to hyperkeratinization. Then there's a lot of, changes in the lipid synthesis, especially the fatty acid compositions. So this patients who are on anti-androgen therapy, they land up with meibomian gland dysfunction. Now, in this case, either you discontinue the anti-androgen drugs, but sometimes because of the gynecological problem, it may not be possible to withdraw it immediately. Then either you can consider giving estrogen supplements, and till there is, till the anti-androgen therapy is going on, you can give supportive treatment for MGD like hot fomentation, lip massage, and preservative-free refreshed tears. So we continued on the patient on that, and there was some improvement. So we had a conversation with our gynecologist, and she has considered reevaluating her, the endometriosis problem and whether the anti-androgen therapy can be reduced or tapered. So moving on to the next case. So this was again a 52-year-old female homemaker who had symptoms of dry eye, foreign body sensation, burning sensation, photophobia for nearly 1 year. And if you see the dry evaluation that we did, the symptoms were significant. On DEQs, it was around, it was high, and she had TBUT was less. The TMH and the Shermer's test, though it was within normal limits, it was on the lower side, and she had meibomian gland dysfunction. So when we found out that she also, along with other comorbidities like hypertension, migraine, she was on antidepressant therapy for 1 year, and she was using two particular drugs. One is amitriptyline, and this second is escitalopram, and besides the other drugs. And this we found out, like, amitriptyline, escitalopram, these are significant cause. They can cause significant dry eye. In fact, some studies have shown that there is reduction in the tear production with this group of drugs. So you have multiple psychotic medications, antipsychotic medications, like tricyclic antidepressants, then selective serotonin uptake inhibitors. And you can see that some of these can cause dry eye. Then you have combination of serotonin and norepinephrine and others like clozapine. The benzodiazepines are less known to cause changes in tear films, but there are some reports. But otherwise, amitriptyline and escitalopram, these are significant causes of dry eye, which can cause reduced altered tear stability, or reduce tear secretion. Now, when we talked with her psychiatrist for for this thing, so she was at first very she was not defensive that probably these drugs, she didn't have other patients with similar complaints whom she had been treating with these drugs. So she only discontinued this mirtazapine, which is a anxiolytic. Now that led, and the patient came back again after 2 years. Now, because of this change only in one, she was having sleepless nights, which again, increased her symptoms, because she fell into a cycle of treatment, then dry eye that was caused by the treatment, and now when we were trying to modulate the our antipsychotic medications, that increased her symptoms. Again, that aggravated her perception about her ocular symptoms. So again, we consulted with the psychiatrist whether either these things can be altered. So these are some of the issues that are significant and challenges which we don't have a ready answer. So the last patient was an 89-year-old retired gentleman who came to us, who had been referred to us because he had developed a corneal Dellen that you can see in the slide in this picture out here. And he had severe ocular surface staining, and the Schirmer's was also relatively reduced. And of course, he had meibomitis. So on taking a history, we found that patient had been diagnosed with squamous cell carcinoma since a year and had been treated by this injection nivolumab and erlotinib. And these, besides other anti-cancer drugs, and these drugs are, epidermal growth factor receptor inhibitors, and nivolumab causes T cell, upregulates the T cell, so it leads to a lot of T cell mediated inflammation. And these can cause severe dry eye. So we consulted on with the oncologist. He discontinued the erlotinib, but this patient required nivolumab because this was systemically much more suitable. So we gave aggressive treatment, but though the ocular surface changes resolved or reduced in one eye, the Dellen was still persisting. So we are planning to take this patient for temporary tarsorrhaphy. So the take-home messages are that when you encounter a patient with systemic drug into dry eye, you can either discontinue the drug, or you can substitute the drug for with some alternative that is more favorable to the ocular surface. Or in some cases, like in a fourth patient where we could not discontinue the levolumab, we have to go in for probably aggressive therapy with lot of something like a tarsorrhaphy. So recognition is very important, and so a comprehensive drug history is important. Now there are umpteen number of drugs that are there. So what I found out in last couple of years is that in dry eye patients, once you take the drug history, you just do a Google search. Most of us have a smartphone or are on EMR, so we are connected to the net. And if we do a Google search, we immediately come to know whether a particular drug leads to dry eye disease. And if we do that, so probably you can, treat it, recognize the condition and treat it effectively. Thank you. So this is for as Dr. Ritu suggested, to give a list of, drugs that can cause dry eye. So I hope, someone can take screenshots and probably keep it, or Google.
This will be available online, so people can always come back to it, and maybe we can post it on our social media as well. And thanks, Amrat. If you notice, I gave you more time because this is very, very interesting and new sort of concept that you thought of, and Dr. Ritu Arora also. And obviously, I'll ask ma'am to go ahead and discuss this.
Yeah, I feel this is one area which is not taken seriously number of times, because another thing to be added, even beta blockers cause dry eye. So whenever we have a patient and we are is not fitting into our typical scenario, whether of a Sjogren's or a rheumatology associated dry eye, it's good to take a drug history. And sometimes we don't even know what they're taking. So I always Google and just see what medicine. And nowadays, a lot of them are taking these antidepressants. This escitalopram is very, very common, and it does lead to dry eye. And he has, of course, enumerated so many other drugs also. So, and some which we may not know. So it's always important to take a drug history. And I've also seen that because diabetes, hypertension is very common, and cardiac problems are very common. So, it's good to go through all those drugs, and if they can be changed, it can improve the condition.
Yeah, I agree, because you see most of this, patients like all these patients, they also had things like MGD, postmenopausal, very elderly. So probably once the drugs were not given, there was a kind of a homeostasis or a balance. But once these drugs are given, probably it tips the balance, and you land up with the dry eye symptoms. And sometimes with the anti-cancer drugs, there are reports of causing corneal perforation, and whether now you have the eye on one side and you have the life on the other side. So I think the fourth case probably would be very challenging to treat. And let me see what the outcome is finally. Thank you. Thank you, everybody.
Yeah.
Thank you, Samrat.
Yeah.
Any other panelists would have any comment for drug-induced dry eye?
So I just had a short
You
comment
didn't
to make.
include anti-diabetic. Yes, Sam.
I think one other one, I guess you alluded to, is oral gliptins, which are used very commonly. There are a variety of them. They're used very commonly for as anti-hyperglycemic because they have a very good profile in terms of not causing hypoglycemia, but they do cause something called drug-induced bullous pemphigoid, and it can start off with as conjunctivitis that is limited to the medial lateral canthus and cause lacrimal gland damage and dry eye. So please do take a history of gliptins, which are also very common. And like Dr. Ritu mentioned and Dr. Samrat mentioned, that neurological medication, antidepressants, antipsychotics, particularly antidepressants, which are used as sleeping pills very commonly over the counter even, do cause it. It isn't exactly dry eye, but it's like a lacrimal gland insufficiency. If you do like a direct assessment of the tear function, you will see that there is a lag in the tear secretion. So tear secretion is normal, but it's not, as the reflex is numbed because they're using antidepressant. There's also a lot of ocular surface disease associated with immune checkpoint inhibitors, which are being used more and more, particularly in the West. There's an epidemic right now happening in the US and in the West because of the use of checkpoint inhibitors. They will be coming to India, so we will have to deal with them soon as well.
Right. Thanks, Sain, for your inputs. So with that, I hand over the last part of today's discussion or today's session for the panel discussion. And Supriya will take over as the anchor along with her team, which is Vaibhav Nagpal and Prajakta Dandikar. And we're a little we're little over time, little late. You can say 10 minutes late. So please go ahead, Supriya.
Thank you, Dr. Somshila and AIOC for this opportunity. I'll just request Dr. Vaibhav to present the first case.
Yeah. Am I audible, Dr. Supriya?
Yes.
So I'll be going through the cases fast, as already mentioned that we are lagging some time. So starting with the case, she was a 32-year-old female. She complained of low vision in the right eye since few months. She also gave history of joint pain and dry mouth since 4 years. She was being treated before as a known case of rheumatoid arthritis since 4 years. However, she stopped her oral immunomodulators 4 months back. And interestingly, she never received any topical therapy in past, but she gave history of use of oral steroids in past. On doing the examination, we can appreciate that the visual acuity in the right eye was hand movement close to face, hand movements with the PR accurate. The left eye visual acuity was about 20/60. On doing the slit lamp examination, we could appreciate diffuse SPKs in both the eyes, and filaments also. And she had a right eye total cataract and left eye had early cataract. On doing the dry eye evaluation, the Shermer's was low in both the eyes. But the direct assessment of tear secretions, when we did, there were about 3 openings of the three lacrimal ducts were observed on both the sides, right and the left. But there was about some low flow on the right side and about moderate flow in the left side. With this, we diagnosed her as a secondary Sjogren syndrome, considering she was already being treated for rheumatoid arthritis. So at this point of time, we restarted oral immunomodulators first and put her on topical lubricants. One was a less viscous and one was a more viscous lubricant. We also started her on topical immunomodulators, that is cyclosporin 0.05% BD. Then after her surface stabilized, after about 6 weeks, we performed the right eye phacoemulsification with IOL with a clear corneal incision. And post-operatively, she's doing well with a visual acuity of 20/30 in the right eye. Currently, we are not doing the left eye cataract surgery as it is early and the patient wants to wait for the left eye surgery. Moving to the questions, Dr. Supriya, please take over.
Thank you, Weber. So first, I'll come to secondary Sjogren's a little later. I'll just want to ask our panelists that in a busy OPD, we normally don't perform tests for dry eye disease, but in which group of patients should we carefully look so that we don't miss out later, because we know that cataract surgery is known to worsen dry eye condition. And if at all, if we are supposed, like if there's a patient who's planned for surgery, which are the basic tests that should be mandatorily performed in these patients before we go ahead with the cataract surgery? Dr. Ritu, could you please share your experience?
I would look at it, yeah. So, either if with a symptomatic patient who's anyway complaining of reduced vision with foreign body, photophobia, what are the typical symptoms of dry eye? There, I definitely like to do the dry eye evaluation. Number 2 are the cases which are the secondary Sjogren syndrome cases, which are, known cases of dry eye. I definitely like to do the dry eye test before, proceeding with the cataract surgery. And here, Shermer's is there, but Shermer's may not give me the exact picture. I like to depend upon NIBUT more commonly, or even, FBUT to see when the dry spot comes up. Just in the busy OPD.
Okay, thank you, ma'am. Another question that I would like to ask our panelists is, which is their preferred choice of intraocular lens, especially when the patient has a high astigmatism. So to correct that, and if you're planning for premium IOLs, which is the preferred lens that you would use in such patients? Dr. Himanshu?
Supriya, I didn't understand what exactly you wanted to ask.
So my question was that in such patients who have poor ocular surface, who've been non-compliant with their medications, which is the preferred lens of following cataract surgery, which is your preferred IOL that can be implanted in these patients? And especially if you want to correct, like if the patient has a high astigmatism, then what procedure would you follow to correct such powers?
Supriya, I still would tell you at the cost of reiteration that when you are not sure about your keratometric values, because when you are treating cylinder, you are treating your keratometric values. Whatever said and done, that the biometry, you may be very confident about biometry, but you're not confident about the repeatability of your cylindrical value. Be very careful before you treat them with any toric lenses. Now, having said that, if you have documented high astigmatism earlier, and if you are trying to treat the astigmatism with a toric lens, it may be fine. But if in doubt, I would avoid putting anything which may be counterproductive later on. So whichever instrument you are using, if your repeatability is good and if you are able to get good repeatable results, I would go ahead with the up to toric part. Of course, multifocal and those things are out of question, and they may not be the best case scenario because they themselves reduce the quality of vision, and on top of that, the dry eye would affect the significant quality of vision. So yeah, up to toric if reliable, repeatable readings are there. Otherwise, I would not go it. Just don't assume that everything, whatever you're measuring, takes care of everything, and go ahead with the surgery.
Okay, thank you, Dr. Manchu. Our next question is that while planning any kind of surface intervention, how would you titrate your immunosuppression therapy? Would you step up the top steroids or systemic therapy, or would you give intravenous immunosuppression just like a single dose after the surgery? Dr. Sain, if you could share your experience on this.
So, Supriya, if you have a patient with an immunological condition, let's say pemphigoid or Sjogren's, who's already on immunomodulatory therapy, then that is going on, then you don't need to do anything extra because you will be after cataract surgery, you'll be using topical steroids anyway, which will take care of any immunological spike or exacerbation if there is there. So usually it's not required. But if you are, let's say, doing surgery very early in a patient who has not been immunosuppressed before but has a very advanced cataract, and you're doing it pretty early on in your management of that case, then you can start with a loading dose of immunosuppression where you would choose an intravenous route. So either intravenous alprazolam or cyclophosphamide or a combination of that. Typically, this would be in management of something that is, more progressive or sight-threatening like pemphigoid, not so much for Sjogren's or for it.
Okay, thank you, Dr. Sain. I think in the interest of time, surgical modifications have very nicely discussed previously by Dr. Ikeda. I think we can skip this and go to the second presentation, Weber.
Yeah. Can I just ask a question?
Yes.
In this case, there was a combination of PG tears and sodium hyaluronate being used. So what do the panelists think about this, these kind of combinations, like do we, combine CMC with sodium hyaluronate or a PEG and a HP Guer with a CMC or this? Can you give the rationale for that combination that was used for this patient?
So to take up that question, Dr. Samrat, so generally CMC is a less viscous lubricant which we use, and we use it much more, the patient uses it much more frequently, but we need a more viscous to have a basal control of the surface and to maintain the tear film. So that is why we used sodium hyaluronate for a basal control and less viscous lubricant, for example, CMC 0.5% for frequent dosing at least about half hourly or 1 hourly. So that was the rationale behind using a combination of drops.
Because viscous fluid was earlier also there, CMC 1%, right? So was the sodium hyaluronate used only for the viscosity, or was it used for maybe it's anti-inflammatory and all those?
So traditionally what we follow, Dr. Samrat, is that just so that like Weber already mentioned, so that the effect of the lubricant that we are using stays on the ocular surface for a longer time. We follow this combination of using 1 drop 4 times a day and probably less viscous, which is more frequently, maybe 1 to 2 times, or it can be even in the form of eye gels, but that usually cause blurring of vision. So we reserve them usually for nighttime when the patient, like just for once daily, like at bedtime.
Thank you.
I just want to make a point here that at times the rheumatologists feel there is no need to step up the immunomodulation, or they may not even give it because they feel it's a burnt out rheumatoid and there is no need. And we as ophthalmologists have a patient who has a very severe dry eye and maybe, end stage rheumatoid, but how do others feel? But I do start them on immunomodulators if I feel dry eye is very severe, and I started on my own. So I just want to know if others are doing the same practice or not.
No, Dr. Ritu, I'll agree with you. That is what we do also. But I would just make the additional point that we must all understand that in the rheumatology literature, there is absolutely nothing to guide the rheumatologist in terms of immunosuppressive therapy for the treatment of Sjogren's syndrome in general and patient and keratoconjunctivitis sicca in Sjogren's syndrome. There is absolutely no evidence which shows that immunosuppression helps. Evidence does not exist. So what they do essentially is that they extrapolate the literature that is available for rheumatoid arthritis, because rheumatoid arthritis is like the most common cause of secondary Sjogren's syndrome, to treat Sjogren's syndrome. Those who do treat it. But it's difficult to expect rheumatologists who have not worked with ophthalmologists before or who do not have experience treating patients with Sjogren's to give immunosuppression, and we can't really blame them for it because they have nothing to go by. So you have to find a rheumatologist who understands the connection and is going to work on your feedback to give immunosuppressions to these patients. But you're right that it does make a difference. It takes about 3 to 6 months for the disease to kind of stabilize, and those patients who can cross that threshold of taking immunosuppression beyond 6 to 12 months do compared to others. We are trying to put together this evidence along with our rheumatologists. So we have formed a group. If you want to join that consortium, I'll ask the person
don't
who's
mind.
working,
I don't mind
putting
that.
this together to get in touch with you. Yeah, I'll touch with you.
Okay, thank you.
The other thing about immunosuppression therapy is also that you have patients who come in with acute episodes. You know, they come in, they're very symptomatic. They have, even if they are on immunosuppressants for, say, the primary, for the Sjogren's disease or ARIA, whatever they have, they come in with ocular symptoms, which are sort of breakthrough episodes, and that requires additional immunosuppression, which again, in the past, I've always had to fight a battle with rheumatologists because for them, the systemic disease is very quiet.
Yeah.
Do you think, like Dr. Sayan or Somshila, that suppose we have these patients who are, say, rheumatoid arthritis for years and years, decades, and they have been on and off treatment, and finally when they come, they have severe dry eye, and also they have severe disease. So would the or even for that matter, not only rheumatoid, even Sjogren's also. So would the immunosuppression, when you give them with immunosuppression, even if the insist on giving immunosuppression and the rheumatologist is not very willing, so do we expect a tear production, or would we just expect a reduction in the tear inflammation? Because probably by that time the lacrimal gland would be very fibrous, would hardly have any acinar cells to produce even if it's inflammation.
Somehow the inflammation goes down, and patients I've found are like much more better. Symptoms wise, they do improve a lot.
So we'll let Supriya take back the panel discussion in the interest of time.
So should I start the second case?
Please.
It's 9 o'clock. Yeah.
Yeah, so second case is a 56-year-old male complained of watering and redness in both eyes since 6 months. The patient complained of even episodes of blurring of vision in both the eyes, which were intermittent. There was no history of using any topical or systemic medication. There was no systemic illness. On examining, the patient had both eye visual acuity of 20 by 20. And on examining the cornea, he had few superficial punctate keratitis in the lower 1/3 of the cornea. The tear film breakup time was reduced. It was less than 8 seconds. The lens was clear, and the tear meniscus height was raised, and the secretion with the lacrimal gland secretion was normal. As we can appreciate through the pictures that the patient had telangiectatic vessels in both upper and lower eyelids with the element of blepharitis and meibomian gland dysfunction. And so the patient was diagnosed with anterior blepharitis with evaporative dry eye. So we started the patient on warm compresses and lid scrubs with baby shampoo. And also we gave a topical steroid antibiotic combination ointment over the lid margin at night for about 2 weeks, and started him on topical lubricants as and when he required with a lower frequency. And he improved over time. And at follow-up, he was much better with reduced inflammation and with better symptoms.
Thank you, Weber. So I would like to ask our panelists, what is there a role of lubricants in such cases of evaporative dry eye? And Dr. Sayan, if you could share your experience with this.
Lubricants are useful, but what we all need to understand is that lubricants are not the treatment for evaporative diarrhea, because you really do not have any lubricants that address the primary pathology. So they do give symptomatic relief, so they're useful in that sense, but you should do all the other things that are required to address the primary pathology, which is myomin gland dysfunction, whether that involves blinking or warm compresses or lid massage or all the other interventions that are there, therapeutic interventions in terms of LipiFlow or IPL, which may need to be repeated. So they do definitely have a role, but they're not therapeutic, they're palliative.
Okay, and what is, in your experience, how effective is omega-3 fatty acids in these patients?
Omega-3 fatty acids are not useful because you know from the trials, the randomized control trial that was done to evaluate the efficacy of omega-3 fatty acid vis-a-vis compared to olive oil, they found that both improve symptoms, but it is not really more effective. In fact, the trajectory was very similar. The relative improvement in both groups was very similar in the DREAM study, and if you are going to give somebody, you might as well ask them to take 1 teaspoonful of olive oil, which is cheaper.
Okay, I think there's some issue with the connectivity.
I feel that omega-3 fatty acids, if at all they are useful in a high dose of 3 grams. But what we normally give to the patient is maybe 500 milligrams, because that one capsule is very expensive. So we are not giving the right dose, and rest, of course, as science said, that they're not been proven to be very good in the long run.
Okay. Thank you, ma'am. What is the therapy for recalcitrant cases, like ones who do not respond to conventional lid massage scrubs and eye ointments? So in those cases, what is your management options? That would be my next question. If Dr. Bhaskar, Dr. Himanshu could share their experience on this.
Yeah, so I would like to take a look at the lipid film as well as the meibomian gland imaging, because it has been proved repeatedly that alone meibomian gland imaging and gland tortuosity or shortening does not consistently uh, go hand in hand with lipid layer abnormalities and evaporative dry eye. So both have to be studied, the lipid layer abnormality as well as the NGD. And if there is a correlation and it is definitely established that is an evaporative dry eye, then and it is not responding to warm compresses, then my preference would be to first go for doxycycline or erythromycin, depending on the age of the patient. And after that, thermopulsatile therapies like LipiFlow and the kind.
Okay. Thank you, sir. For Dr. Himanshu, sir, I had a question for you. Amongst the various options that we have today with respect to diagnostics and intervention when it comes to treating dry eyes, which according to you is most important or crucial? Like if anyone wants to take one device, for example, pick up one device for diagnostic as well as therapeutic purpose, if at all they are important, and to what extent, and which device should one prefer?
So I really don't think dry eye practice is device dependent as much as we project it. Simple things done, proper clinical examination, and I vouch on fluorescent staining itself uh, tells you a huge amount of stories. Having said that, if I have to make a comment, that one device which I possibly would love to have, and which would be meibography, though having said that, meibography can be performed, and I've been doing meibography with autorefractometer for like ages together. I can't even remember how many years. So so in any ways, wherever, if you are able to image the meibomian glands, and which may help you in deciding your treatment protocol, whether you will still be going with meibomian gland expression in whichever way, whether it's mechanical, whether it's warm compressive lid massage would give you a result, or if there's significant loss of gland, and there your choice of lubricant may alter. So you may want to give a lipid based lubricant or an ointment based lubricant in such kind of scenario. So Yeah, I would love to have something which tells me about that. In the treatment part, there are a lot of variations now, and the meibomian gland expression can be done in multiple ways. So, need not to have a very funky device which you always have. Delivering heat in a controlled manner in whichever device works in your hand, along with an expressive expressor, which can be a manual expressor, can be quite useful. So you need not to have very expensive setup to have an effective dry eye clinic, according to me.
Thank you, Dr. Himanshu. In the interest of time, do we have time, Dr. SS?
Yeah, you can take a few more minutes.
Yeah, just we'll go ahead with Prajakta presenting one case.
Thank you, Dr. SS, for the opportunity. Am I slides moving?
Yes, Prajakta, you can go ahead.
This is a case about it's a 70-year-old female patient who came with the chief complaints of pain and watering in both eyes since 3 months. The cataract surgery in both eyes was done 15 months back. That is, the patient was suffering for almost a year. The patient was kept on CMC eye drops for last 2 months. And this was a picture in her eye. So the visual acuity in the right eye was 20 by 600 and the left eye was counting finger 1 meter. You can see the picture in the lids are slightly thickened with the with conjunctival congestion, and there are these redundant folds of the conjunctiva which are there inferiorly, suggesting conjunctival calluses. And you can see the scarring. There is central and inferior scarring in both eyes. On fluorescein staining, we found that there was punctate staining in both eyes with confluent staining in the central and inferior part of the cornea. The Sherman's test without paracaine was 7 millimeters in the right eye and 3 millimeters in the left eye. Whether this was a case of conjunctival calluses which was causing these symptoms and scarring, or it was a case of dry eye, because the patient, we could not do the DATs of this patient because patient had a lot of photophobia and a lot of blepharospasm. We could not examine the lacrimal palpebral lobe of the lacrimal gland. So how do you go about these cases? And these are the questions to the panelist. Dr. Supriya?
Yes. Dr. Ritu, if you could share your experience with such cases.
As I look at these pictures, to me, they appear that there is an associated limbal stem cell deficiency in these cases. If you really look at though the inferiorly, there is present this kind of an opacification in the cornea. I mean, I don't know if it was looked for, which could be associated with dry eye. Yes, conjunctival calluses is there, but they normally present with dry eye kind of features. Sometimes they have epiphora also. So, and if they don't resolve with our main lubricants, sometimes once or twice I have done the conjunctival fold has been snipped to make the conjunctiva taut.
Yes, ma'am. So, like a couple
are purely due to conjunctival calluses. In this patient, to me, it doesn't appear that it is purely due to conjunctival calluses. Maybe other panelists can opine about it.
If you have a patient who has signs which are mostly localized inferiorly or more prominent inferiorly, particularly if you have a chemos conjunctiva, which is then giving the impression of conjunctival calluses because it's chemosed and then it's folding with the lower lid. Sometimes it could be because of drug toxicity. So this is sometimes you'll see this in patients who are on chronic AGMs. That is something to be ruled out, or even patients on any kind of preserved eye drops. Sometimes patients are chronically on anti-allergic eye drops which contain BAK, or they're on vasoconstrictive eye drops like nafazoline, etc., which can cause this. Sometimes they just use over the counter. So with the clinical picture that you presented, with the way that the lids look and the clinical picture, you would want to take a detailed drug history in this patient, particularly the use of topical medicine.
Yes, Dr. Sain. So we actually asked for, because of the confluent SPK is localized to the inferior half of the cornea, we had ruled out the drug history in her case. So she was not on any kind of AGMs, And the lubricants also, she was not using very frequently. She was using maybe 6 times a day. That too was not very compliant with using the lubricants. As Dr. Ritu rightly pointed out, that she complained of severe pain and she had the epiphora. Contrary to what you would see in a patient of dry eye, she did not complain of any kind of grittiness in the eye. So in these cases, do you think we should be addressing the conjunctivochalasis, or we should evaluate the patient further for any kind of underlying connective tissue disease?
You would think about addressing the conjunctivochalasis if you are sure that is what is causing the symptom. If there is coexistent conjunctivochalasis or there's a fold in the conjunctiva, that doesn't necessarily mean that that is causing the symptoms or the signs that the patient is, bothered about, or what is causing the patient the symptoms. So that, I think, needs to be established, that the conjunctivochalasis is the problem for you to surgically manage it.
Okay.
The opinion of the house is that we need to relook at this case, and I don't know if I've seen the case, but it actually looks like the patient could be using some traditional medication instilling in the eyes or something like that.
So I think one important thing which we should remember, that when we talk about conjunctivochalasis and when we are talking about cutting the remnant conjunctiva, we are talking about rest everything normal, the patient having significant epiphora, and which is leading to increased lower tier meniscus height, and which is leading to the problem, and that's when you want to do that procedure. Now, when you have a significant ocular surface abnormalities and significant staining and a lot of other things going on, creating an injury on ocular surface may not be the smartest thing to do at that point of time. When your Shermer's values are 3 millimeter, your secondary conjunctivochalasis is related to dryness, and I would rather treat that rather than trying to snip off conjunctiva and create more ocular surface problem. So remember, both are very different, and I don't think there's any confusion where we try to snip the conjunctiva in an abnormal surface versus somebody with a significant regular surface, but just remnant and fold of conjunctiva where you can sort of snip it.
Okay. Thank you. Thank you, Dr. Manju.
So Priya, you can take maybe 2 minutes for one more scenario and then hand it back to me.
Sure. Prajakta, could you just go through quickly?
This is a 73-year-old male patient. He underwent cataract surgery in the right eye, which was complicated because of PCR. Then thereafter, he developed CME, for which injection Ozurdex was given, and he developed secondary glaucoma, secondary to steroid. And so he was placed on Combigan eye drops in his right eye. So he had this unilateral glaucoma, and somewhere he was diagnosed as dry eye disease for the right eye and was prescribed lubricants in the right eye. So this was the clinical picture. In the right eye, his visual acuity was 20/80. And you can see that there is a mechanical ptosis and conjunctival congestion with punctal pouting. And there was more congestion was noted in the inferior part of the conjunctiva than the superior part. So we thought that this patient is allergic to the HEM or showing signs of drug-induced cicatrizing conjunctivitis. So we stopped the Combigan eye drops and we shifted him on Dorzox preservative-free eye drops. So this was his picture after 3 weeks of stopping the medication, and we also placed him on topical steroids. So the question is, how do you approach such cases? And is like in this case, the patient responded, but every time shifting to the preservative-free eye drop, will it help? Because eventually AGM is also responsible in some way to cause the damage on the surface.
So this is very interesting. I'll just make a point quickly that it is true that the molecule itself, for example, brimonidine itself, may be toxic or the patient may be reacting to it. But what is very interesting is that the combination of the molecule and benzalkonium chloride is a kind of a synergistic effect, has a synergistic effect that exaggerates the effect on the ocular surface. In isolation, they are much less toxic.
This is very
so along with, I think along with talking about shifting to preservative-free lubricant, we should be insisting our glaucoma colleague to shift them on preservative anti-glaucoma medication, which works much better than only shifting to the lubricant and taking care with the lubricant.
Yeah, this patient was shifted to preservative-free anti-glaucoma.
Yes.
Okay.
Also, while in the acute phase, we would start the patient on topical steroids, and once we taper off the steroids, would the panelists recommend maintaining some kind of topical immunomodulators like cyclosporin or tacrolimus in such patients so that there is no further progression or worsening?
So I'll say two things, Supriya. One is that the first thing is, of course, to confirm the diagnosis that this is drug-induced, not to assume necessarily just because the patient is using AGM-1 that it will be attributable to that. Because, for example, a case of pemphigoid can also present in the same way, and it can just be coincidental that the patient in the same eye as well. So the first thing is to test your hypothesis, which is basically to stop everything, give a drug holiday, preservative-free lubricants, and wait for a couple of weeks. And typically the patient will show some things will improve, some things will stay the same, and some things will worsen. So what will improve is the patient's symptom and signs. So patient will feel better and the conjunctival inflammation will go down. What will stay the same is some of the secretorial changes, fibrotic changes will stay the same. And what will become worse is, for example, if the patient truly has glaucoma, if you stop the anti-glaucoma medication, the IOP will rise. So that will tell you that, yes, this medication is responsible. And I do use preservative-free lubricants and also preservative-free cyclosporin for these patients, because since they are also glaucoma patients, using topical steroids is a little bit risky.
Yeah, this is what my point was. We can't keep them on steroids because they are glaucoma patients, because he's probably got glaucoma in this patient because of the Ozidrex.
Yeah.
So we have to be a little careful in that. And the
Dr.
cataract
Samrat,
surgery somehow doesn't appear uncomplicated. There seems to be a lot of shaffing there.
Yes.
So I do not know if that is the cause, if at all, for glaucoma, because, or it's the Ozidrex. I mean, that has to be seen.
Yes, thank you, ma'am. Dr. Samrat, would you share your experience in these such eyes? Like, what is your preferred management option in these cases?
Actually, I've had a couple of patients of glaucoma with this. So, as the others have said, stop the drug and substitute it for the thing. I've given all these patients topical steroids and they have regressed. And I've kept them on follow-up because, again, whether I'm dealing with only drug-induced or whether it's OCP. In one case, which had come during COVID times, there was significant corneal opacification and vascularization. And that has significantly reduced after we switched the patient from brimonidine to dorzolamide and timolol, I think so, and tried to get them to use preservative-free AGMs. So now we have a lot of companies that have preservative-free AGMs, and I think that is done. So, but the good point about these cases are that if you can identify and diagnose, withdrawal of the drug is the way to go. But with OCP and all, the thing is progressive and you need to give on immunosuppression.
Yes, absolutely, sir.
All drug-induced systemic and everything, if we can stop the inciting drug, recognize and stop the inciting drug best. If not, then we have to either lower the dosage or give aggressive treatment for the condition.
Yes, thank you, sir. Thank you so much.
Thank you for the last session, Supriya, Vaibhav, and Prajakta. I think you made it very interesting. So it's my pleasant duty now to thank all our panelists, speakers, and chairs who had joined in this session today. I think the presentations were just fantastic. Each and every presenter we had today did a marvelous job and also stuck to time. Thank you very much for that. I just enjoyed the discussion and everyone brought so much value, whether it was Dr. Ritu or it was Dr. Namrata, of course, Sayan, Dr. Geeta, and Samrat, Bhaskar, and Himanshu. All of you brought so much value to today's discussion on dry eye. I'd recommend again later that if you could share this link on your social media handles so that more and more people can watch this. Though it turned out to be much more in a sort of an advanced case scenario, case setup for dry eye, but I think there were a lot of interesting discussion points, and these cases are not going to be so rare or so abnormal. So I think it's worthwhile for the general ophthalmologist to be well aware and at least take the initial steps that are needed to treat these patients. And let me not forget to thank Mr. Kripal Rana and Sunil, and of course Dr. Santosh Honavar, who's attending the Andhra Pradesh state meeting, so he couldn't be here. Dr. Manoj Mathur, Dr. Samar Basak, and Dr. Namta Sharma from the AIOS team who have helped us put together this webinar. So thank you, everyone. And sorry, I failed on my promise. We are still a little over time, but I think it was worth the while. Good night to everyone. Thank you.
Thank you. Thank you very much. I learned a lot. Thank you.